Today we are starting a series of lectures on lung tumors, right? Tumors from the lungs. Now, today about the lung carcinomas, we'll talk about a very special subset of lung carcinoma, which is called Pancoast tumors, right? So what we are talking about? We are talking about a very special subset of lung tumor, which are called Pancoast tumor. Now, Pancoast tumor, why we are studying it? Because it's a very classical example how the anatomical position of a lesion can eventually translate into pathophysiology and how we can link it with the symptomatology. Now, let's come back. Here we have the lungs. Now, the uppermost part of the lungs, suppose this part of the lung, which is the uppermost part of the lung, this is called apex, right? Now, this apex of the lung, this basically all tumors, right, which are present in apex of the lung, right, or right, they are called Pancoast tumors. They are also called superior pulmonary sulcus tumors. Why they call superior pulmonary sulcus tumor? Because you can look at it. This is the apex of the lung, and this subclavian artery, which is arcing over part of the lung, one of the uppermost part of the lung, and first rib, that leaves a little shallow groove there. That is why the tumors which take origin from the uppermost part of the lung, they are also called, yes, they are also called apical tumors or superior sulcus tumors. Now, what we really see that, first of all, what kind of lung tumors appear here, right? Now, diagnosis of Pancoast tumor is not histological. It is not histological. It is due to its anatomical location, because it produces very unique set of symptoms, very special set of symptoms as compared to other lung cancers, right? Now, other lung cancers, for example, we talk about cancers which are here taking origin, we call them central lung cancer. They most commonly, histologically, they are squamous cell carcinomas, or they are small cell carcinomas. These are central tumor, right? Basically, they have bronchogenic origin, right? And they are now squamous cell carcinoma, you must be knowing, they take origin from the, well, yes, their cell of origin is basal cells present in bronchial lining, right? And these cells which are present in the bronchial lining, if they get metaplastic and they make squamous epithelium, that squamous epithelium can convert into squamous cell carcinoma, and it is very commonly found in people who are smoking, right? Then another type of lung cancer which can take origin in centrally, more commonly, more often, even though it can be at other places, but more often here, that is small cell carcinoma. Small cell carcinoma, the cell of origin is neuroendocrine cells, or we also call those cells cultured sky cells. What do we call them? Cultured sky cells. Then there are lung cancers which are more abundantly present in the periphery of the lung, right? For example, they are present over here, they might be present over here, or they might be present over here, or now these tumors which are on the periphery usually, and of course apex is also coming the periphery, so these can be there also. Now, these peripheral tumors most commonly histologically, they are, yes, histologically they are adenocarcinomas. They are adenocarcinoma, and their cell of origin is adenocarcinoma, and the cell of origin is type 2 pneumocyte in the alveoli. You know, there are type 1 pneumocyte which play a role in, let's suppose if this is alveolus, there are type 1 pneumocyte, right? And then there are cuboidal shaped type 2 pneumocyte will, and then again type 1 pneumocyte. Now, these type 2 pneumocytes, right, if they get malignant, they make adenocarcinoma, right? And actually these type 2 pneumocytes are surfactant producing cells, but they are also responsible for regenerative capabilities here, and type 2 pneumocyte also play a role in defense system or immune system related with the alveoli. Now, what did we learn up to now? That even though most commonly we classify lung carcinomas according to the histopathology, right? But Pancoast tumors are very different, right? How they are different? That Pancoast tumors most commonly, there are two types of Pancoast tumor, right? There is, yes, squamous cell carcinoma, very commonly there, and other very commonly tumor present over here is adenocarcinoma. Traditionally, squamous cell carcinoma was considered most common Pancoast tumor. What I mean by this, that traditionally it was considered that in the apex of the lung, the most common histopathological variant is squamous cell. But these days, adenocarcinoma's incidence is increasing, and in many parts of the world, the most common carcinoma in the apical region is adenocarcinoma, right? Now, it is adenocarcinoma or squamous cell carcinoma, right? Or even large cell carcinoma, right? Any histopathology, all of them are labeled as Pancoast tumor. All of them are labeled as Pancoast tumor. Now, question is that why there is a special name given to these tumors which originate at the apex of the lung, right? There is a reason. The reason is the tumors which are in other parts of the lung other than the apex, their clinical presentation is different. They usually produce bronchogenic symptoms. For example, these tumors which are not Pancoast tumors, they come with the new cough or intractable cough or persistent cough or altered cough or cough with hemoptysis, or they present with dyspnea, right? These are the features of most of the lung cancers. But Pancoast tumor, they present very differently. As they are away from the main bronchial system, so originally or initially, they do not present with very prominent bronchogenic symptoms. Again, it's worth repeating. Pancoast tumors, why they are separated with the rest of the lung tumor? Answer is, Pancoast tumors, even though they are just like other lung carcinomas, but due to their special and unique anatomical position, right, as they're away from the main bronchial system, they less often present with cough, hemoptysis, and dyspnea. They more often present with complications they produce in the neurovascular entities or components around the apex. Now, let's see what is the exact position of apex. Again, for example, all of you know that just above the apex there is brachial plexus going, right? Now, these tumors will go and hit the brachial plexus. But of course, tumor which is here, it is not going to hit the brachial plexus. So, one of the early features will be due to involvement of the brachial plexus, right? And if they are involving the brachial plexus, that will present with neurological complications. And unfortunately, these neurological complications are with especially sensory problems like pain or paresthesias, they will be referred to the shoulder or to the arm, right? There, so patient will be unfortunately referred more commonly with this cancer by general physicians, not to the pulmonologist or pulmonary oncologist, but to the rheumatologist. And due to this reason, diagnosis become late and disease become advanced. So every good medical person should remember that Pancoast tumors are having a very unique importance due to their anatomical position, that there is something special which they don't have, and there are something special they have. The something special which they don't have is that they don't have very prominent bronchogenic clinical features. They do not present classically with like other lung carcinomas which present with cough or altered cough or newly changed cough or persistent cough or cough with hemoptysis or with dyspnea, right? These tumors which are at the apex, they usually present by the symptoms which are produced by invasion of this tumor to the surrounding neurovascular structures. It means to truly understand the clinical presentation of and symptomatology of Pancoast tumor, you must know that what are the structures which are around this area. Here I would love to highlight one thing, that let's make one more friend here, and this friend is large cell carcinoma, right? Because at the apex of the lung, right, or in the superior sulcus area of the lung, squamous cell carcinoma can be there, adenocarcinoma can be there, large cell carcinoma can be there. So, in many places in medical literature, we say that Pancoast tumors, even though anatomically they are at a unique position in the apex of the lung or in the superior sulcus, but histopathologically they are usually not involved by small cell carcinoma. They have large cell carcinoma, squamous cell carcinoma, adenocarcinoma. Presently, most common adeno, then squamous, and then large cell carcinoma. Right? Now, these three, if you put together, we can say non-small cell carcinomas. What we can call it? These three, we can call them non-small cell carcinomas of lung. So now we can say the apical tumor of the lung, they are most commonly non-small cell carcinoma, and it's worth repeating that they do not present with classical lung cancer symptomatology like cough, hemoptysis, and dyspnea. Rather, they have a unique presentations due to which, if you don't have clinically high index of suspicion, you will not diagnose it, you will miss it, and patient will miss the life because disease will get very advanced by the time you diagnose it. So it's very important to understand that how this anatomical position dictates very unique symptomatology, right? Now, first of all, I would like to highlight this apex. Exactly what is this apex? Come over here. This is thoracic inlet. Thoracic inlet is basically aperture, right? We also call this superior thoracic aperture. This is also thoracic inlet, right? Here it is very simple diagram, just boundaries shown. Here important components are also shown or contents are also shown. Now first we look at its boundaries. Thoracic inlet or superior thoracic aperture, that number one, here on the back it has T1 vertebra. On the sides, both sides, it has first rib along with its cartilage. First rib along with its costal cartilage, right? And then this area is upper border of manubrium. What is this? Upper border of manubrium. So what is thoracic inlet, right? Thoracic inlet is basically a special thoracic aperture which is present in uppermost part of the thoracic aperture, where many important neurovascular and other structures are passing from neck to the thorax and from thorax to the neck and also to the arm, right? Structures just above it, they are going to the arm like brachial plexus. Or you can see it here, that here is thoracic inlet. This is T1. Here is trachea, but just behind it there is T1 vertebra and first rib. And you see that in this thoracic inlet, in this diagram, we have shown some very important neurological component which I will discuss in detail very soon. And subclavian artery is also going towards the arm, right? Axilla, actually, to be more accurate, and subclavian vein is also going over there. Now, so we can say that apical part of the lung is that part of the lung which is just above the thoracic inlet protruding in the root of neck. Uppermost part of the lung which is covered by the thoracic inlet, and it is protruding in the root of the neck, where there are so many important neurovascular structures, right, which will be involved by this cancer, and they will produce very unique clinical features which usually point to some other diseases like diseases related with rheumatology, right, or neurological diseases, and not point to the typical features of lung carcinoma. And this type of lung carcinoma usually are misdiagnosis for a very long time until they become really very advanced. So that is why I chose that this should be the first lecture in the series of lectures on lung cancer. Right. Yes, ma'am, you have a question.
Sir, at what stage can we diagnose them?
I will come to that. She is saying that most commonly at what stage they can be diagnosed, right? Now, first thing, if you really want to diagnose relatively at early stage, if you really want to diagnose these tumors at relatively early stage, you should have high index of suspicion clinically, because the clinical presentation is what? That here is this is T, look, here is brachial plexus, right? This is C5, 6, C5, C6, C7, C8, T1 segments and their origin. Now this is brachial plexus. I have discussed in detail brachial plexus, but actually apex is somewhere here. Lung apex is coming somewhere here. Yes. Producing very unconventional you can say presentation. Now, lung cancer is just below the, what is this? Brachial plexus. When it will start invading the surrounding structures, right? So naturally, first it will invade on the side. On the side, it does not go much, because here in this area and this area, the apex of the lung, apices of the lungs are protruding. In this big diagram, this is the thoracic inlet aperture, and these are the cut section, cross section of the lung apices, right? Now, if you see there, just here you find T1. It means here actually brachial plexus is going on, or from here it is going up and it is going towards the brachial plexus, right? Now, in the proximal part of brachial plexus. So the first neurological involvement, how this, first I will tell you the structure involved, then I will tell you the symptomatology, which should not be missed. Now, these tumor, when they grow upward, because they cannot grow sideward much, on the sides there are ribs, they don't give much growth area, and here there is what? Vertebra. Even though these tumors can produce erosions of the ribs and also erosions of the vertebral bodies, which produces pain, and that pain is called nociceptive pain, which is constant, dull, and gnawing pain. But what I'm saying, that not only they involve the ribs by the erosion, which is, and they can also involve, what is this, at advanced stage, vertebral bodies. The very important involvement is here. I must highlight it. What is this involvement of? Brachial plexus T1. I mean this structure. This is this structure, right? Here this, and here it is this. Here I have not made the upper part. Now, usually it involves the T1. And then when it further goes up, it can go to C8. So classically, most commonly, this tumor involves brachial plexus with C8 and T1. And the moment it involves the lower part of brachial plexus, we say it is already at stage 3A. It is already at stage 3A. But how it goes over there? First, it has to go through visceral pleura, because this apical carcinoma is going to spread extrapulmonary in the root of the neck, where neurovascular structures are very crowded. So when it will go out, it will go through visceral pleura, then it will go through parietal pleura. Now, parietal pleura also produces pain. It has pain receptors. So let me show you here that as it is going up, okay, so it will pass through visceral pleura, and then it will pass through parietal pleura. Parietal pleura has pain receptors. So this is one origin of the pain. Then on the side, it goes to the ribs, region of ribs, periosteum, that also produces pain. Then it can go to the back, to the, what is this, vertebral body. Here periosteum is also having pain receptors, right? So these are some of the origin of the pain. That can be rib, that can be vertebra, that can be parietal pleura. Plus, just above the parietal pleura, there is some thickened fascia. This is endothoracic fascia. We also call it Simpson's fascia. Simpson's fascia. This also has pain receptors. And after that, it will go above, and then it is, what is it? T1, and here it is going C8, and this is lower trunk. These are C8 ventral rami, or C8 root of the brachial plexus, and this is T1 ventral rami, or T1 root of the brachial plexus. Now, this tumor will go through all these structures. When it is spreading, not only it is going to the ribs or vertebral side, vertebral usually late, but very early they involve parietal pleura, Simpson's fascia, and then lower part of brachial plexus. Now, these structures will produce pain. Why? Because these tumor cells, cancer cells, when they will reach there, they will infiltrate these especially neurological structure, The first structure to be involved most commonly is lower part of brachial plexus. There are 2-3 ways how it damages it. Number one, initially it grows as a mass and it compresses that. Then it infiltrates and irritates the neurons, which overfires and eventually destroys. Right? So all these things specially damage C8 and T1. And now look at it. This is C8, this is T1, here's the upper trunk, and there is lower, yes, cord, which eventually is giving rise to, what is this nerve? Ulnar nerve. So you need to remember that whenever we talk about Pancoast tumor, you must talk about ulnar nerve related problem. That this is ulnar nerve. When you are basically destroying or irritating or compressing, you can say is C8 and T1 root value or the lower trunk of the brachial plexus, actually you are damaging the ulnar nerve. But at the same time, what is the classical and most frequent presentation of these patients? Up to 96% of this patient come with shoulder pain. 96% of the patient come with shoulder pain, and almost, unfortunately, in many parts of the world, almost 96% of the patients are initially misdiagnosed in many parts of the world. Why? Because shoulder pain, you think of frozen shoulder, you think of some radiculopathy, right? And you refer the person to the rheumatologist, or you feel if there's some neurological problem, right? You refer it to the neurologist. But actually, this is a case of pulmonary oncologist. It's a very unusual thing. That's why I'm focusing especially on Pancoast tumor. So classically, the most common presentation is shoulder pain. Along with that, right, if vertebrae are involved and other structures are involved, then there can be pain on the back of the chest, periscapular pain, especially on the medial side of the scapula, right? Then you should not forget, what is this? Ulnar nerve. Ulnar nerve complications will appear. The sensory complications will be that you will have, if nerve is irritated, you have hyperesthesias. Hyperesthesias and tingling, right? Tingling sensations along the ulnar nerve supply. Ulnar nerve supply is especially medial side of the forearm and 1.5 medial most fingers, pinky and the ring finger, right? On the palmar side as well as on the dorsal side. So what you have a patient who come initially with the shoulder pain, right? Unfortunately, they are referred to rheumatologist or neurologist. But if it is Pancoast tumor, they say if there is intractable, severe shoulder pain which does not get relieved by usual drugs which are used for killing the pain in rheumatology, it does not resolve by that. Think of apex of lung. There is something there, right? So patient will have shoulder pain. Along with that, he might have periscapular pain, and due to ulnar nerve involvement, pain may be referred to the medial side of the, remember, here from the brachial plexus, there is a cutaneous nerve of the arm and also cutaneous nerve of the forearm, and there are cutaneous nerve related with 1.5 medial most fingers, right, on both sides, palmar and dorsal. So what will have, patient will have severe shoulder pain, which is refractory to most commonly used analgesics, especially it becomes intractable at night, right? And this is neuropathic pain. Now there's a difference in nociceptive pain and neuropathic pain. When bones are damaged, fascia are damaged, right, we say there's nociceptive pain, right? And when nerve itself is being damaged, we say there's neuropathic pain. Both of them are treated differently, which we will discuss later, right? So basically, the pain which this patient have, it has both type of pain, nociceptive pain from damage to the non-neurological structures, and it also has a neuropathic pain component, which is coming from damage to the lower part of the brachial plexus, right? And so medial cutaneous nerve of the upper arm, medial cutaneous nerve of the forearm, and even ulnar nerve sensory supply. So these will be some clinical features which are initial, right? But the very sad truth is that stage 1 and stage 2 are usually not diagnosed, very rarely diagnosed, because patient really becomes serious and doctor becomes serious when there is severe shoulder pain which cannot be managed by routine management or rheumatological or neurological management. By that time, someone thinks that they should do chest x-ray or CT scan or MRI, and you find the tumor mass there in the apex of the lung, right? Now, along with this pain, right, or sensory complications, there are also motor problems, because ulnar nerve carries motor fibers for some of the forearm muscles, but for a while forget, but never forget, ulnar nerve terminal branches are supplying the motor fibers to the intrinsic muscles of the hand. Most of the intrinsic muscles of the hand for ulnar nerve supplies all the introccii, dorsal introccii and palmar introccii. Ulnar nerve specially supplies, yes, medial most two lumbrical muscles. Ulnar nerve also supplies all hypothenar muscles and some of the thenar muscles. So it means that if ulnar nerve, if C5, C8 and T1 damage is going on, ulnar nerve is being damaged, and the motor supply here is T1. Here is T1, right? And that will actually eventually lead to the atrophy of the most of the intrinsic muscles of the hand, right? And which muscles, especially thenar muscles, hypothenar muscles? All of them. They are supplied by the ulnar. Most of the thenar muscles and all deeper muscles, like not all, fourth and third and fourth lumbricals and all introccii. So what will happen? Hand will become hollowed up, right? Because muscular mass atrophies and disappears. So there will be hollow here. And in some cases, it will show claw-shaped hand. That I will explain in ulnar nerve palsy, that why the hand may become claw-shaped. And patient will have motor function problem, his grip will be loose, and dexterity, the fine hand movements, patient will not be able to perform, right? So this is one problem, that this patient will present with shoulder pain, right? Again, what are Pancoast tumor? Pancoast tumor are a special subset of pulmonary carcinomas, which are anatomically present in the apices of lungs, which are part of the lungs, which are above the first rib and protruding into root of the neck. Is that right? And these parts of the lungs, when they develop cancer, right, they classically, initially they do not produce bronchogenic clinical features like cough, hemoptysis and dyspnea. Initially they produce shoulder pain, periscapular pain, and pain going down, radiating to the back or to the neck, or most commonly along the medial side of the arm, forearm, and ulnar side of the hand. Is that right? And along with that, so now we have seen sensory complications and motor complications. Along with the brachial plexus, you see what is here? This is sympathetic chain, right? So we know that sympathetic chain is present, is a bilateral structure paravertebrally. It is present on the vertebral bodies on both sides, sympathetic chain, and this is stellate ganglion. Now, what is stellate ganglion? Let me explain this. Stellate ganglion. Actually, sympathetic chain has superior cervical ganglion, then it has middle cervical ganglion, then it has lower cervical ganglion, and then it has T1 ganglion. Now, what happens? This is superior cervical ganglion. Right from here, fibers are going upward to the head and neck. Then this is middle cervical ganglion. Then inferior cervical ganglion. And what is this? T1 thoracic or ganglion. Right? This is sympathetic. Now, when these two ganglion fuse with each other, this is a very important anatomical point. These two ganglion, when they fuse with each other, which ganglion? Lowermost of the cervical sympathetic and uppermost of the thoracic. They fuse together. This is called stellate ganglion. Stellate ganglion. So what is stellate ganglion? Stellate ganglion, you see it is present over here. Here is it. So when this tumor, which is present over here, right, our dangerous tumor, and in the apex, so angrily it is spreading, it will spread not only surrounding bones, ribs, and vertebral body, but when it goes upward, because it cannot go outward much, go upward, first it will catch what? Brachial plexus, lower trunk, or T1 root. Then, if it goes a little medially, then it will catch, what is this? Sympathetic trunk. And which part of the sympathetic trunk? Stellate ganglia, classically. It will involve, catch the stellate ganglion. Now, when it will destroy the stellate ganglion, then sympathetic supply to the head and neck on this side will be interrupted. On this side, what will be interrupted? Sympathetic supply. Now, when this sympathetic supply will be interrupted, what will happen? Actually, the sympathetic supply from here, if it is destroyed, right, of course, all pathways going up are not working, right? The fibers which are going up, they do, number one, half of the face or ipsilaterally from this side, ipsilaterally, number one, they provide to the all sweat glands. We call them pseudomotor fibers. These pseudomotor are SUDO, pseudomotor, not PSUDO. Pseudomotor, it means sweat nerve fibers which supply the sweat glands. So what happens? If these fibers are, stellate ganglia is involved, right, then upgoing oculosympathetic fibers are disrupted, right, and this will clinically translate into loss of sweating on half of the face, right? And whenever this person has some exertion, the normal side will sweat well. Look here, normal side will sweat well. The side which is involved, it is not sweating at all. We call it anhydrosis. What we call it? Anhydrosis. Anhydrosis. Right? Now, when these fibers eventually go further up, sympathetic, one of their very important function is that they do sympathetic supply to the ocular system, to the eyes. Now, let me draw an eye here to make the things really clear. Sympathetic supply to the eye. Number one, here I draw Here's eyeball, and here is upper eyelid. Upper tarsal plate, here is lower tarsal plate. This is normal person, and here's the muscle to pull the upper lid upward to open your eyes, right? So to upward this muscle, it's very important to understand it has two types of fibers, right? This is one group of fibers, and this is other group of fibers. One group of fibers, this is called tarsal muscle. Tarsal muscle, or it is also superior tarsal muscle, or it is also called Muller's muscle. Tarsal or Muller's muscle. This is involuntary muscle, right? And it is controlled by the sympathetic tone, and it helps the upper eyelid. Once you open your eye, it helps you to keep the eye open automatically, right? This is superior tarsal muscle, or its other name is Muller's muscle. So sympathetic nerve supply is coming here, but there is another part of the muscle which is also attached to the upper tarsal plate, and it pulls it under voluntary control, because voluntarily also you can open your eyes, and that is supplied by oculomotor nerve. Oculomotor, third cranial nerve, but this is supplied by oculosympathetic pathway. Now, when stellate ganglion is damaged, this ocular sympathetic fibers, we call them oculosympathetic fibers, they are disturbed. And when these fibers are disturbed, oculosympathetic pathway, it means tarsal muscle or Muller muscle is not working. It means one of the muscle which elevates the upper eyelid, that fails, Muller's muscle. So upper eyelid will have slight drooping. Upper eyelid will have slight drooping, right? So normally what happens, this is a normal eye. Normally what happens, okay, before the eye, I make the limbus. From the front, if you look, this is pupil, this is iris, here is also, let's suppose, pupil, and here is iris. Normally, in anatomical position, when some person is looking straight, lower eyelid is at tangent with the lower limbus. Upper eyelid normally is slightly covering the upper part of the iris, normally, physiologically. Now, when this muscle of Muller will fail, or superior tarsal muscle will fail, then it will slightly come down. It is partially covering, very little. It will drop down further, and this pathway, lower will remain at the same, but upper lid, this will come much lower, maybe up to here, or even it might cover the pupil. It depends on how much damage is there, right? So when this occurs, we say when upper eyelid is drooping, right, we call it ptosis. P is silent, ptosis. So these patients will develop ptosis ipsilaterally, anhidrosis ipsilaterally. With that, there is one more thing. Here there is iris. Here there is iris and ciliary body, and now here is iris, this is iris, and this is iris, and behind that there is ciliary body here, ciliary body, and this is choroid. I'm more concerned with the iris, because central aperture of iris is actually pupil, right? Now, If I draw the iris in frontal view, I will draw iris like this. This is pupil, this is iris. Now, iris has two types of muscles. Number one, radial muscles, which pull the iris, pull the pupil margin outward. When these muscles, these are radial muscles, they are attached on the periphery, and when they contract, right, they are attached to the limbus, and when they contract, they basically dilate the pupil. They are mydriatic muscles. Eye, pupil opening, not eye opening, pupil opening muscles. And then there's another type of muscle here. They are like ring structure, and these rings is constrictor pupillae. So these blue fibers are constrictor pupillae and red fibers are dilator pupillae. What I want to highlight that your red fibers, which are dilator pupillae or radial fibers, they are also supplied by the sympathetic fibers. They are also supplied by the sympathetic fibers. So when your stellate ganglion is damaged, from here, when your stellate ganglion is damaged, right, what will happen that not only you will lose sweating on the half of the face, right, not only your upper eyelid will droop pathologically, we call it ptosis, but we will lose the function of, what is this, dilator pupillae, right? When dilator pupillae loses its function, we can say that constrictor pupillae is unopposed, because constrictor pupillae is supplied by the parasympathetic fibers, which are coming with the oculomotor nerve, which are not interrupted. Normally, the pupil size is determined by the balance of the sympathetic and parasympathetic tone. Sympathetic are controlling the dilator pupillae, and parasympathetic are controlling the constrictor pupillae. So in these patients, dilator pupillary system stimulating sympathetic fibers are damaged, and then constrictor pupillae muscles, which are supplied by the parasympathetic component of the third cranial nerve, right, via the ciliary ganglion, this parasympathetic fibers here, they keep on working unopposed, and they lead to the pathologically small pupil. We call it meiosis. So we call it meiosis. You can look at this diagram, that here there is sweating, here there is no sweating. It means there's n hydrosis there, number one. Number two, you look, here the upper lid is pathologically drooping. Here upper lid is here, but not drooping too much, right? So, and third thing, here pupil is quite big. Here pupil is small. So we say that three classical features of oculomotor sympathetic fiber failure is anhidrosis, yes, ptosis, and then meiosis. And in this case, palpebral fissure, the area between the upper eyelid and lower eyelid, it will be smaller, and eye may look as if it is slightly pushed backward. That condition is called anophthalmos. So there may be apparent anophthalmos, that anophthalmos, that apparently due to smaller fissure, it appears as if eyeball is slightly sunken in the orbit as compared to the normal eye. Now, these three features, due to failure of the sympathetic supply to the eye, right, these all anhidrosis, ptosis, and meiosis, and if there is anophthalmosis, all this as a group, this group of symptoms or presentation is called Horner syndrome. This Horner is with H. It is not Horner syndrome. It is not Hor. No, it is Horner, from Horn. Horner's syndrome. So what did we learn up to now? We learn up to now that number one, what are Pancoast tumor? Pancoast tumors are the pulmonary carcinomas which are present anatomically in the uppermost part of the lung, or they are called superior sulcus tumors or apical tumors, right? What is apical part of the lung? This part of the lung is above the first rib, and through the this aperture, thoracic inlet or superior thoracic aperture, they are protruding to the what? In the neck, right? They are protruding in the neck. This is inlet, and they are protruding here and here, and here there are very important what? Neurovascular structures and other structures, and these tumors which are in the apices of lungs, right, they are usually not diagnosed early or misdiagnosed because they don't produce classical bronchogenic features of lung cancer, right? They do not produce, initially at least, not with the suspicious cough for hemoptysis or dyspnea. They classically present these tumors when they spread in the surrounding structure and start damaging, right? They may produce rib erosions or vertebra erosions, and they involve lower part of the brachial plexus, the T1 root or C8 root, or trunks, inferior trunk, right? Due to these involvements, they produce a very special type of clinical feature, which are unfortunately uh, treated by just simple painkillers, and that is they initially produce in almost all patients, 96% of the patients, they come with the shoulder pain, right? And then the shoulder pain eventually get referred in the back, or it start referring downward, and you develop sensory abnormalities along the medial side of the arm, especially on the ulnar side of the arm, because medial cutaneous nerve is also damaged. Medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, and other ulnar supply. That lead to initially tingling in these areas, right? Or lancinating pain, like a sharp pain or electrical like pain. This is when tumor is irritating the nerve fibers. We call it neuropathic pain. And when some fibers are damaged, then relevant areas become numb. They don't have any sensations, loss of sensations. So the sensory abnormalities. Then there are motor abnormalities also. With the time they develop, they are related with the ulnar nerve. You can see it from here, damage to the T1 and C8, or lower trunk, which is having fiber from T1 and C8. They eventually go to the ulnar nerve, and of course some of them go to the median nerve, but we are not discussing that right now. So they are going to the ulnar nerve, and ulnar nerve is the main supply to the intrinsic muscles of the hand, that is small muscles of the hands, all hypothenar muscle, most of the thenar muscles, because some other are supplied by the median nerve on thenar side, and then all antrochiae and two medial, third and fourth lumbricals. When all these muscles they lose their motor supply, not only a hand grip is weak and fine movements of the hands are difficult, rather shape of the hand also becomes abnormal. Thenar eminence is lost, hypothenar eminence is lost, and your fingers go to the claw shaped, which I will discuss in ulnar nerve palsy. So these sensory and motor problems, right? Along with that, as tumor, if grows medially, it will hit the, what is this? Sympathetic trunk. And when it hits the sympathetic trunk, what will it do? It will produce failure of the it will classically damage the stellate ganglion, right? You know, stellate ganglion is inferior cervical ganglion plus first thoracic sympathetic ganglion. Usually they are fused together, so we call them stellate ganglion. When this ganglion is invaded and destroyed, right, that will lead to failure of the sympathetic motor fibers going to the ipsilateral head and neck lead to half anhidrosis with ipsilateral drooping of the eye, which is ptosis, along with that meiosis due to unopposed parasympathetic action of the sphincter pupillae and failure of the sympathetic supply to the dilator pupillae. And so what is there? Anhidrosis, meiosis, ptosis, and apparent anophthalmos. All these features are Horner syndrome. Now, there is a saying that if a patient with shoulder pain develop with Horner syndrome, patient with shoulder pain or arm neurological abnormalities or ulnar nerve area related abnormalities with what is this? Horner syndrome. It is Pancoast tumor until proved otherwise. Right? And this combination of these features is called Pancoast syndrome. This constellation of clinical features. What clinical features? Shoulder pain, sensory abnormalities on the medial side of the upper arm, forearm, and other part of the 1.5 finger on both sides, sensory abnormalities along with the atrophy of the intrinsic muscles of the hand and weakness of the grip and fine movement, right? All these things plus Horner syndrome. This combination is called Pancoast syndrome. What is it called? Pancoast syndrome. So Pancoast tumor is something else. Pancoast syndrome is purely clinical thing. When we say Pancoast tumor, we are talking about pathological lesion which is present in the apex of the lung, most commonly primary carcinoma, Pancoast tumor, right? And when anything present over here, it may be tumor, carcinoma, primary carcinoma, it may be secondaries. Lungs also receive a lot of metastasis, especially from the thyroid cancer, breast cancer, colorectal cancers, prostate cancers, and many others. Sometimes secondaries come over here, and these secondaries also spread. What I mean by that, they go extrapulmonary in periapical area and destroy the neurological and vascular structures and bony structures related with the thoracic inlet. Even those secondary tumors, they're also producing, they are not called Pancoast tumor, but symptomatology is called Pancoast syndrome. So Pancoast tumors are strictly referring to the primary lung tumor, which are usually non-small cell carcinomas, rarely small cell carcinoma, present in the apices or apical region of the lung. But Pancoast syndrome is when something in the lungs apices, some pathology in the lung apices is damaging, what is this? Lower part of brachial plexus, and also, what is this? Stellate ganglion, right? When these two are involved and the symptoms related with these two dysfunctions are coming, then we say Pancoast syndrome. Now, Pancoast syndrome most commonly is due to Pancoast tumor, right? In the apices, most commonly it is due to Pancoast tumor. But this can be metastasis also. It can be some other tumors also. There might be this lymphoma here, plasmacytoma is there, or there is some destructive infective element here, like staphylococcal or other pyogenic abscesses present over here, which from here they spread upward and backward and medially and involve neurological structures, especially lower, what is this? Brachial plexus and stellate ganglion. They will also produce Pancoast syndrome, but they are not Pancoast tumor, right? In the same way, some fungal infections here like aspergillosis, fungal balls, they can damage, right? And if they go beyond extrapulmonary, right? So actually, Pancoast tumor is a specific term which is used for primary lung carcinomas which are anatomically initiated or produced in the apices of lungs, right? The part of the lungs which are above the first rib, in the root of the neck. This is Pancoast tumors, right? Pancoast syndrome is when any pathology in the apical area, right? Apical area, this pathology may be primary carcinoma, it may be secondary carcinoma, right? Or it may be infections or any other pathology which goes extrapulmonary upward and medially. So when it will go upward, it will damage what is this? C8 and T1. And when it goes medially, what is this? Stellate ganglion. Is that right? Then less often they involve the vessels, which I will talk later, right? Then other nerve, which is very important, that is this nerve, which is going upward. We have already talked about involvement of brachial plexus. We have already talked about involvement of stellate ganglion. Now let's go. The tumor goes more deeply and medially, and it grows towards the mediastinum, right? Especially between the trachea and esophagus, and there is recurrent laryngeal nerve. You know, recurrent laryngeal nerve is a branch of the vagus nerve. On right side, when vagus nerve is going down, it gives recurrent laryngeal nerve which loops around the right subclavian artery and goes upward to supply the all intrinsic muscles of the larynx except cricothyroid. But the root of recurrent laryngeal nerve on the right side is different than left side. On left side, vagus nerve goes more deeper and down, and the left recurrent laryngeal nerve loops around aorta, and then it moves upward and eventually it approaches between the groove between trachea and esophagus and reaches to the larynx. And when it reaches to the larynx, again same thing, on ipsilateral it will supply all the intrinsic muscles of the larynx except cricothyroid, right? Now what we have seen, we are going to the third neurological complication. First was problem, it was involving brachial plexus and symptomatology, then stellate ganglion and symptomatology. Now we are going to the recurrent laryngeal nerve. This is the recurrent laryngeal nerve here. Recurrent laryngeal nerve on both sides, and here we have recurrent laryngeal nerve here. This tumor, if I show from here actually, so this tumor, if it is present over here, it has involved, what is this? Brachial plexus. It has involved the stellate ganglion, and it has gone to the recurrent laryngeal nerve, and of course ribs and vertebra are also involved. Now when recurrent laryngeal nerve is damaged, right, this is more commonly damaged in Pancoast tumors on the left side because it has a longer root there. Here it loops around right subclavian, here it loops around aorta, and it has a longer ascending pathway. So once the recurrent laryngeal nerve is damaged, right, what will happen? Dysfunction in function of the larynx, right? Phonation will be in problem, coughing will be in problem. Basically vocal cords, they cannot move normally, they become semi-paralyzed. And when vocal cords are not working well, or they are in paramedian position fixed and not working well, then what will happen? Person voice will be showing hoarseness. Their voice will be showing hoarseness, right? And this will be prolonged hoarseness, right? More than 2 weeks, 3 weeks, 1 month. So persistent, prolonged, refractory hoarseness of the voice. With that, if you ask the person to cough, because to produce cough, you need to bring the both vocal cords together and raise the pressure what is in the lungs, and when pressure in the lungs become too high, then suddenly you move the vocal cords open and close, open and close. During this, air explosively comes out and cough is produced. But because these do not properly close, so pressure does not build, so properly patient cannot cough, and that cough, which is somewhat hollow cough or breathy cough, we call it bovine cough. So these patients have problem with the speaking, so they develop hoarseness, they develop bovine cough. Another thing, which usually most of the doctors forget, that recurrent laryngeal nerve not only supplies a motor component of the larynx, intrinsic muscles, it also supplies the mucosa just below the vocal cords. It means sensations are lost. This increases the chance of aspiration, and that is why in these patients aspiration pneumonia is also common, right? You know, your mouth is full of anaerobes, and what will happen, that saliva usually you swallow, and if larynx function is intact, then saliva will not be allowed to go to the respiratory system. But if your larynx's vocal cord don't approximate well, epiglottis does not cover the larynx well, the laryngeal dysfunction increases the chances of what? Aspiration pneumonia. So hoarseness of voice, bovine cough, and more chances of aspiration pneumonia. Then it can go to other nerves. Here we can see this nerve is phrenic nerve. Now, phrenic nerve with root value of C3, 4, 5, right? If this tumor has gone, again, it has gone up and involved plexus, it has gone up and inward and involved stellate ganglion, it has gone too much inward and medially and recurrent laryngeal nerve, it has gone interiorly and involved phrenic nerves. When it involves phrenic nerve, what happens? Actually, phrenic nerve is nerve supply to the hemidiaphragm, one phrenic nerve. So ipsilateral hemidiaphragm does not work. So ipsilateral hemidiaphragm paralysis occur, and this produces difficulty in breathing, especially in those patients who are already having compromised respiratory system. And as you know, that many of these patients with Pancoast tumors are smokers, especially patients who are having squamous cell carcinoma. So if they are smokers, usually a male smoker more than 50 years old, having intractable pain in the shoulder and having sensory and motor abnormality in the region supplied by the ulnar nerve. Think of lungs. It will be very sad when you diagnose this patient. By the time it involves the stellate ganglion and Horner syndrome also appear, and when brachial plexus, lower brachial plexus failure features plus Horner feature together, we call it Pancoast syndrome, right? But other structures, as it keep on spreading, right, more complications appear, right? For example, as I said, here there was pain and motor problems, muscles of the hand. Here it was Horner syndrome, right? Here it is recurrent laryngeal nerve, hoarseness of voice, bovine cough, and chances of aspiration. Here is phrenic nerve involvement, hemidiaphragm paralysis or paralysis. Then, in some advanced cases, tumor goes along the perineural, grow along the nerve roots medially, and it goes through intervertebral foramina to the spinal cord. In very advanced cases, up to every fourth patient might get this problem. Thus, this tumor not only is growing upward and outward, but also goes medially, right, and even in mediastinum. And when it goes very posteromedially, this may grow along the, what is this? Perineural sheaths of nerve roots, right? and through intervertebral foramina, it may enter into a spinal cord. First, it will produce mass effect outside the dura mater, or sometimes it damages the dura mater also if it is producing enough proteolytic enzymes or digestive enzymes, and many tumors produce such destructive enzymes. Then it will damage the, what is this, spinal cord, and we say there will be myelitis, which will lead to the, number one, both legs paralyzed, we call it paraplegia. Along with that, there may be abnormal functions of bowel and bladder, right? So that is really very sad situation, advanced situation, right? When it catches, what is this? Brachial plexus. We say it is already at stage 3, stage 3A, right? If T1 is involved, okay, T1 is involved, it is still resectable. But if it has gone above and beyond, then resection becomes difficult, even though now modern technology is coming. Usually, how do we diagnose these patients? First of all, you should think of the X-ray. But remember, many a times in X-ray, these lesions are missed. Sometimes we can catch some opacity in the apical area. Better than X-ray is CT scan, right? Which is especially good in showing the tumor, and also CT scan show the ribs and what is this? Vertebra. But golden test must be MRI, magnetic resonance imaging. In MRI, you can even see all soft tissue invasion of the tumor. Even you can see that which component of the, what is this? Brachial plexus is involved, stellate ganglia is involved or not, or even you can see that perineural sheath and going towards to the spinal cord, how much it is involved. So MRI is the classical golden test in this situation, right? So how many neurological complications? First, we have talked about two complications, which were basically, what is this? Osteological complications, that is erosions of rib and vertebra. Two. Then we came to the neurological complication. One was brachial plexus complication. Number two, stellate ganglion. Number three, radial nerve. Number four, phrenic nerve. Number fifth, spinal, going to the spinal cord. So how many complications? 5 neurological complications and 2 bony complications. So it becomes 7 complications. Then, as you know, here is subclavian vein and here is subclavian artery. Veins are thin-walled and collapsible. So sometimes tumor mass compresses the vein, right? And if it compresses the vein, then venous return from the ipsilateral arm will be impaired, and that will lead to the swollen arm or edema in the arm, right? And in the same way, if it goes downward mediastinally, it may catch the or grab the superior vena cava. And if it involves the superior vena cava, it will produce superior vena caval syndrome, in which there will be drainage of the superior vena cava will be impaired, right? That is head and neck and on both sides, of course, because you have one superior vena cava to drain both sides. So in this patient, it's very advanced stage when tumor has gone to mediastinum and there it involves the superior vena cava, then venous drainage will not be proper. So all veins in the head and neck will be engorged, distended. In upper limbs also distended. In upper chest also veins distended, and face will be swollen, right? And if you look at the jugular venous pressure and pulse, of course, jugular venous pressure will be very high, and of course, pulse will not be there because jugular venous pulsations are due to atrial contraction. But if atria is contracting here and superior vena cava is caught here, then atrial contraction cannot be propelled back to the jugular venous system, right? So less commonly there are vascular complications, and in vascular complications, two venous complications, subclavian vein complication where arm gets edematous, or more dangerously which is really a medical emergency, superior vena cava syndrome, right? And very less commonly, it may involve the artery, subclavian artery, because artery is thick walled and high pressure, and usually it resists. But if mass effect is there or damage is to the artery, then of course ipsilaterally blood flow to the arm will be less. So if you compare both arms, then you will have you can say 6 P's of ischemic limb. This limb, if subclavian artery is compressed and blood flow here is reduced, then this limb will be painful, right? Then it will be pale, then it will be pulseless or altered pulse, weak pulses as compared to the other side. Then even blood pressure on both sides here will be less and there will be more. Then there is a term called pykilothermia. Pykilothermia is inability to regulate the temperature in that part of the body, because sympathetic blood flow is not coming properly. So you are unable to increase blood flow in heat, and you are unable to constrict the vessels and reduce blood flow in cold temperature. So your arm is at environmental temperature. So temperature regulation fails in that arm. So what is there when it is obstructed? What is this? Or compressed, which is less common, but it might occur. That is pain in the limb. Limb is painful. It may be having pulseless or altered reduced pulse, or there may be pallor, or there may be pykilothermia, plus there may be paresthesias, because ischemic paresthesias, right? So this will lead to limb ischemic features. So in the end, how many structures involved? At least we should have 9 to 10 complications you should know. Again, I will come over here. Tumor is in the epiphysis here. Number 1, it goes up and involve the brachial plexus. Then number 1, okay, start with the bones, easy to remember. Erosions of ribs and erosions of vertebra, these two. Then neurological, 5 neurological complications. One is brachial plexus, then there is stellate ganglion, then there is recurrent laryngeal nerve, then there is phrenic nerve, and then transverse myelitis, or not transverse myelitis, just myelitis, because right, and that lead to quadriplegia and other things. Now how many complications? 5 neurological and 2 bony, 7. Then 2 venous complications. One is subclavian obstruction leading to arm edema, other is superior vena cava syndrome, and 1 arterial. That now it completes 10 complications related with Pancoast tumor. But remember, again, there's a difference in Pancoast tumor and Pancoast syndrome. Pancoast tumor can produce Pancoast syndrome, right? Pancoast tumors are the tumors which are primarily originating in the apical part of the lung above the first rib. Pancoast syndrome is any pathology in the apical part of the lungs or superior sulcus of the lungs, which may be primary tumors, which may be secondary tumors, which may be infections, or any other destructive lesion which is expanding and showing invasive complications in the root of the neck, right, and producing Pancoast syndrome, which is classically having 3 features. Pancoast syndrome has 3 features. Number 1, shoulder and arm pain and hand pain, especially in the ulnar division area. Number 2, atrophy of the intrinsic muscles of the hand. And number 3, Horner syndrome, right? And how do you treat this situation? You will refer it to the oncologist. Usually what they do, first they debulk the tumor by chemotherapy and radiation, and if it gets small enough, then they do surgery, right, and try to of course you need to sacrifice some structure, but try to preserve as much function as much possible. Thank you very much.